No, that's great. Thank you. So we're going to have a short kind of panel discussion now. Folks can ask questions, and Dr. Siddiqui will moderate.
Okay. And so, does anyone have any questions? We have Dr. Dreyer and Michael Peters and Alberto.
And Safwan, where's Safwan? Maybe he's outside.
I have a question. A friend of mine has this nice new wrist, not me, of course, that's fancy and new and very capable, supposedly, that I would like to ask the vendor to be able to reach into the medical record, our HIS, to look at GFR, for IB contrast exams. Cross-check the med, see if there's a metformin-related med, or try to get some intelligence on what the person may have that might be a contraindication for contrast. I mean, just some basic things, but just wondering if that's a reasonable thing to ask of them. Is there some sort of model for that, or experience with that ability? So when a person is on a metformin drug or has asthma, for example, can look and flag it and say, well, maybe you should reconsider. I mean, we're looking at all this, but it's a manual process. Your eyes have to go to many different places. Right. And I think, I don't know, just if you could help me put that in perspective.
Yeah, is this working? Yeah. I think it's very doable what you're requesting. I remember at Penn, and the folks are here, so they will not allow me to lie. Many years ago, we said, well, gee, there's so much information out there about this patient. How come I'm here on my PACS workstation, very powerful. I have a dictation system, but I don't have all this information that's still circulating out there. So this idea of dashboards that capture the information. My only recommendation here is to stick to the standards, because the standards gives you two things. One is vendor independence, which is critical. Everybody's talking the same language, so you can go best of breed on your department and still get information from others. The way we have implemented, we don't have an HIS, we don't have a higher entity, right? The RIS is our EMR, is the private practice. On our e-prescribing module, you can pass that information, and then it goes against a database of a SureScripts or some other vendor out there that it returns to you an adverse contraindication information. So there are two ways of doing it. I think you can do internally with your hospital, makes a lot of sense, or you can go externally with a private outlet via the interface that I talked about.
Yeah, what we've done consistently, I think, through the times when there weren't necessarily standards to move that in a constant way, is we've created a dashboard interface at the desktop, so kind of context sharing, if you will. And as Jacob mentioned, the info button kind of approach, where basically what you're saying is, I know the context of this patient, and I know the setting that I'm in, and now I can ask specific questions consistently in that situation of my EMR and be able to pull back that information like the GFR. So that's typically how we do it, and we found challenges in doing that. Safwan, come on up. Is in getting that information that changes consistently, not just the numbers inside, but we say, boy, now we'd love to have these 3 or 4 or 5 more elements in that step where we're making a diagnosis, and then writing all of those algorithms to go out and mine that data out of the systems. I've found that that's what I'm encouraged about seeing with all the efforts around standardization from the ONC, is that when I look inside of EHRs and try and pull out something like a GFR, you do it once for one system, and then you got to start all over again if you change EHRs. Or if you're at 4 hospital settings, you have to rewrite the code to connect it up to it today.
Any other questions?
Dr. Hirschhorn's asked a question.
So, Alberto, how are you going about sharing images and radiology reports with your patients?
Well, I think two steps to that. One, we are currently rolling out the patient portal that has the results, the reports, but no images. The vendors are all lined up. They like to receive an image or perhaps a link to launch that application elsewhere. But for us in radiology, It's critical, and we talked about key images for many years, but if we're not selecting in a study what the key images are, then going forward, if you want to send an image to the EMR, it's clear EMRs are not going to be PACS. At best, you're going to send one image, a screen capture, a representation of that study. Then not having that key image is a big impediment for that. And so first, for us, is an education of the patient to use the portal as an access of electronic data, limit the reports and all that other information that we have. And then an internal education for our folks to start marking images as key, a representative image in each study. So later on, we can mine only those key images and pass that to other applications or launch our PACS remotely, sort of just a link. But we haven't tackled the images for the patients yet. Patients got a CD, typically, with images today.
Okay. Any other questions?
Yeah, we hear a lot from, we have a kind of a vast array of members, from kind of small private practices to large practices to academic centers. And what we hear a lot from some of the folks that are, dealing in private practices, how do I get started? Where do I go? Where are the resources? So that, at a high level, so maybe the question to the group is, what's our answer to those folks? How do you suggest they kind of dig into some of this?
Well, this is a challenge. What I always say is to try and gain as much information as you can. It's out there. The problem, I think, a couple years ago was most of the information was misinformation. I think a lot of it's cleaned up today. I think the big question you have to ask yourself is, am I compliant? Or am I eligible first? Am I eligible for this program? And I think the good or the bad of that is, to most radiologists, that answer turns out to be yes. So then the next question is, how on earth do I comply? And so I took probably 5 questions after the last presentation, the folks that came up to me and gave me their story, which is not uncommon, but it seems to be always unique, and that is that I work at multiple hospitals. We have multiple imaging centers. Most of our hospitals don't care about this. They don't even know what it is when I talk to them about it, yet we feel like we have to do something. What do we do? And so I start teasing through their common technology platforms to try and find out what's the same at all of their organizations. And it might be like their reporting solution is the same. And so then I look for those common threads and I say, well, then that's where you really should try and work with vendors to say, is there anything you can do to help me over the next year or two? What can I put in place? Some people look at options like, and I'm giving you the difficult cases. The great cases, where maybe you don't even hear it, is, I got pulled in by my CMO or my CMIO, and they said, you're part of the plan, and you're all covered, and you're all taken care of. So that's the good news. These are the tougher ones, where people are trying to figure out, what do they put in? Some people ask the question, well, Practice Fusion is this certified EHR product that's free, but it doesn't really integrate, and it's certainly not made for radiology. So should I go do that and take that approach? And there's no cookie-cutter solution, so I think you just have to kind of ask the questions, like come to these kind of events, ask the questions and figure out what's the best fit for you. And comforted at least somewhat by the fact that if it absolutely doesn't work for you, there is a mechanism for hardship exclusion there, finally, in the regulations. That's my thought, but I'm curious what you guys think.
Does this work? I'd also point out that, just anecdotally, as staff who answers a lot of questions from folks who are having problems finding information or understanding the regs, I'd say 60 to 70% of the questions I get can be answered just by reading about the regulatory requirements themselves and understanding those. And ACR certainly has resources where people can do that. We have a meaningful use resource webpage with summaries of the July 2010 final rule and of the September 4th, 2012 final rules. We look at both the ONC certification criteria final rule and the CMS's meaningful use final rule and incorporate those into a single summary. So at least, skim over the materials that are available and sort of understand the regulatory framework. And then from there, certainly you can contact me, you can contact anyone else. There's a regional extension center program that HHS has set up that provides consultation. So, there's various ways to get more information.
And I think one of the other ways that smaller groups, I think one of the biggest complaints of smaller practices is that you know, the big institutions have dedicated people to do MU and to look at the stats, and they have statisticians and they have IT, you know, resources. But you could actually, I think they're very willing to discuss, you know, some of those things with the smaller groups. And I think there's a huge incentive for us to all be aligned in whatever location or geography. You know, if I want to call Keith or somebody at Wisconsin or you know, Brigham and Women's, I think they'll be very willing to discuss how they got to where they are for meaningful use. And I think you see a lot of the barriers are trying to be broken by the ONC. You know, they're very small, reachable goals that many institutions can get to. And the other thing too is that they've been pouring money into health IT for these smaller groups. A lot of these smaller practices are very IT savvy. It's just leveraging that information and making it, you know, useful, and it's there. It just has to be coordinated and done in a way that you can get the reimbursement and not be penalized, you know, when we get to 2015.
You know, my thought was, I think it reminds me of PAX 15, 20 years ago, where we had conferences, sessions, these national presentations of how to do archives, how to read cases, what kind of monitors to put up, and then this slid over to the responsibility of the vendors. And I think it's probably going to be similar, but we're in that transition phase where there's a lot of fact-finding that needs to take place, and even the vendors are trying to stay up to speed on this ever-changing component. But I would ask you, and this is why I'm always eager to take questions, I would ask you, what is it that you think that we could do? And if we don't want to discuss it in this forum, that's fine, but please let the ACR know. One of our board members, we had a healthy discussion with a couple weeks ago, who said, you know, what I think we should do is have a flow chart, because there's so many different buckets that people are in, and you have to know so much even just to figure out what bucket you're in. That could we create a little tool for people to be able to answer some simple questions and get them to the point to realize where they're located, and then we can direct them toward targeted information. So we're trying to do more and more for our members, but if there's any thoughts or concepts or challenges that you have, it'd be great to hear them.
Just to finish, for us, I mean, it has the benefit of being a large group, we get attention, but it has been leveraged on our vendors, our partners, right? Vendors is very sort of antagonistic, but our partners. And they brought in that to us. Early in the process, as early as 2009, we had our first Meaningful Use meeting. I slept through most of the meeting, but later on I heard that it was about this. But it was our partners that brought this in and said, this is coming, and this is out there. So a lot of the vendors really did their homework for stage one, and I think there's a lot to be leveraged from them.
With respect to clinical decision support and use of appropriateness criteria, where do you see this technology being most effectively leveraged? At the level of the referring physician or interfaced with the risk system, or at the level of the radiologist, where they may take it as a request for consultation and then enter a final order based on the use of this criteria?
So I'll speak first, because I would probably scream if I couldn't. So I think that it's going to be all over the place, right? And I think it's going to be at the point of care or the point of service, which is the most appropriate place for it to happen. Right now, it's kind of disappointing. It depends if you're a clinician who doesn't want to do this, or you're an IT person who thinks that this should have been done a long time ago. As to when you look at the clinical decision support that's put into the systems today for imaging, I think they're woefully deficient. There's just so much information and clinical guidelines that could be incorporated and should be incorporated into these systems. So my bias, let's break it down just a little bit. When we look at the ordering of images, or those clinicians that need to order, I think there's a lot that could be given to them at the point where they're ordering that could be independent of a radiologist consult. National standards and national consensuses of information that are available to clinicians to make the right decision. And then when it gets a little too far, there can be an interaction with the radiology group. Radiologists themselves at the time of protocoling can also have standards that they can use and adhere to do that. And then even more so, radiologists that are doing interpretations. When they see findings, there are standards that they could adhere to be able to say, I need to comment on these areas because I've found this thing, and I needed to have language in the report that speaks to that, and I needed to have a standard recommendation that then communicates, and then you can track and adjudicate that process afterwards, that teed off by that standard decision support that's in the system. That's where I think we need to get to, and I think that, you know, Jacob, when I did ask him that softball question, I think that's directly where they're headed. And when we look at stage 1 and stage 2 decision support, it's the precursor of what's really going to happen, which is much more directed, much more specific, which needs to happen. Does that answer your question? Okay. Any other-
I'd like to ask another question.
1 second before that, though.
Sorry, I have a mouthful about decision support, which we'll be talking about this afternoon, but I agree. I think it's going to be at every level. I think it's going to be at the ordering provider level. It's going to be at the physician. What we're having a big issue with are the people that are ordering on behalf of physicians. A lot of them don't have the inherent knowledge of the patient presentation, the clinical history, and to be able to use the decision support properly. So I think there's going to be a huge push to try to get physicians, more physician ordering, and at the other end, the protocoling is going to be done by physicians. A lot of places it's done by the technologist or the CSR. And I think that's going to be a major shift to how decision support is going to be used.
So another question.
Yes, my other question, which is a more general, you were talking about the trees of what goes on in your own institution and your interaction with your own physicians, but what about communicating between institutions? If a patient is at Mass General last week and then they're on vacation where I am in Florida and they get sick again, how is that information going to move from one place to the next? And where is this all heading? Because that's real meaningful use.
And I can give you, again, my opinion with what I looked at and saw as proposed in stage 2 and then pulled out was the potential for tighter image communication to the patient and to other providers. So I think that that's going to come back in and is going to be there. I think that there are going to be technological solutions that are available from vendors today that allow that interaction to happen. The question always is that a patient-directed activity, physician or provider-directed activity, federally mandated activity? Does it use health information exchanges? Does it use cloud solutions? Does it use point-to-point? Does it use solutions like Dr. Mendelson's approach with the RSNA for sharing? So I think the technological solution is yet to be determined, but I think the feds and CMS, this payer of a lot of the care, realizes that without that, there's a tremendous amount of redundancy that happens and problems with the system and communication if we don't put those solutions in place. I think it's just a matter of how and when that they're going to kind of put the foot down. There was another question over here, too.
Just briefly, this was touched upon a little bit, but how is there a position for the ACR on how to handle IV contrast? Is it considering a medication or just a part of the general procedure, and how that interfaces with meaningful use? And at our institution, we're still struggling with, does it require a radiologist to directly order into our system? Any comments about that?
Well, in the confines of the EHR incentive program, the standards, the vocabulary standards associated with medications is RxNorm, and RxNorm, if anyone's familiar with it, explicitly does not support contrast media, radiopharmaceuticals, and other things being in that particular standard. Even if you were to sort of treat contrast media as being a medication, there's no way you could capture that information as structured data and comply with the CPOE requirement in meaningful use. So that's one of the reasons why I brought up the prescription verbiage change as being one of the concerns. Also in the, I think someone, Dr. Murray Riker from DR Systems brought up the point that also in the CPOE objective for stage 2 and in the change for stage 1, they're going to make the exclusion fewer than 100 medication orders, where it used to be 100 prescriptions, so that could have implications on that as well. But I would say that contrast media is not a medication, because if it was, it wouldn't be supported by the standards in this particular program. So what I'm saying may not be applicable to other things and other guidelines that we have that deal with things outside of the meaningful use world.
But going back to the question is what's your philosophical point of view as to who's in charge of deciding what test is to be done at the end? Is it the radiologist that determines? There's a lot of places that do generic ordering. They will order a head CT. It's not designated. Is it our job, is the ACR's job to inform people about what the right test is to order, or is that the responsibility philosophically on the radiology department?
Is a contrast a medication that requires actual entry into the hospital pharmacy system and then essentially is treated like a dispensable medication. There are people at our institution that see it as, well, it's potentially can cause life-threatening reactions. You need to pre-screen the patients. It's like, it has to be treated like Lasix or any other medication that's dispensed in the hospital setting. And, we've been going around and around with that. I'd be interested to, from an operations standpoint, to hear how other institutions have addressed this. I mean, it's helpful. It isn't considered part of the meaningful use thing for us.
Just to, I think what Mike said is nails it. It's a consumable, a supply, as far as meaningful use is concerned. But you cannot administer contrast if you don't have a physician present. So there is that sort of dual standards out there. But for meaningful use purpose, gadolinium and all those contrast agents are just supplies. They don't get ordered or dispensed.
We should probably wrap it up.
Okay, yeah. So we're running short on time, so thank you, everyone.